Good morning, everybody. It is a great honor and pleasure for me to be invited to this prestigious Congress. And yesterday we had a very nice pre-Congress course with very good videos, and it's really a pleasure and an honor for me to be invited here to give a talk. And my special thanks go to Bülent and to Mustafa for organizing this wonderful Congress. So my task today is to tell you about the Western approach of BCLC-A in hepatocellular carcinoma. These are my disclosures. So some introductory words. So primary liver carcinomas are the 5th most frequent tumors worldwide and the 3rd most frequent tumor-related death cause. Globally, there is an increasing and rising incidence, and we expect in 2025 about 1 million new cases per year. And as we all know, it's the most frequent cause of death in patients with liver cirrhosis. And if you have a look at the maps on the right side, you see we have different prevalence, different incidence around the world, and I think this is one of the reasons why we here have a Western and an Eastern perspective talk. So we have different guidelines around the world. We have the EASL guideline in Europe, we have the AASLD guidelines, and we have the HEPATO guidelines for the Asian and Pacific area. And these guidelines in some points differ. But I think if you have a lot of experience with resections in cirrhosis and in resections in hepatocellular carcinoma, you might more go to the Asian Pacific guidelines than to the EASL guidelines because they are very restrictive. So this is BCLC criteria. You all know about this. We have the green area, the early stages, what is traditionally meant for surgery. Then we have the yellow area, what is traditionally meant for the interventional radiologists. And then we have the red area with the advanced disease, what was traditionally the part of the hepatologists and the oncologists. So we kind of have an anatomical targeting in this BCLC criteria. So today, mostly my talk will be about this area, but I think the stages during the very good efforts in the last years, the stages kind of mix up in the future. So if you plan surgical therapy for HCC in the Western countries, of course it is necessary to talk about resectability, and we do this in the multidisciplinary tumor board. There you have to make individualized concepts for every patient, and certainly general operability has to be checked. Oncologic resectability does make it sense to resect it. Functional resectability, what is very important in HCC and in cirrhosis, you have to have enough functional liver tissue afterwards, and of course technical resectability. And all disciplines meet together and we make individualized concepts for our patients in the tumor board. So concerning liver surgery for HCCs, all of these mentioned procedures are performed for HCCs depending on where the tumor is located, how big the tumor is, and how the liver function is. So very important, as depicted here in red, is that we are able nowadays to perform almost all of these procedures minimal invasively, like full laparoscopic, or since a couple of years we also started and are successful with robotic-assisted surgeries in HCC. And of course, one of the main treatments for hepatocellular carcinoma in the livers with bad function is liver transplant. So full-size transplantation, split transplantation, living donor liver transplantation are very established methods to do it. So as Vogel et al. Recently published in the Lancet seminar paper for BCLC-A, the 5-year overall survival rate after resection is approximately 70%, but unfortunately, as you all know, the recurrence rate is very high. It's about 80%. So what about liver transplantation in HCC? We have distinct selection criteria, the so-called Milan criteria, you all know about them because the paper is very old. It's from 1996 when Mazzaferro first published the Milan criteria in the New England Journal of Medicine. So single tumor at least 2 centimeters and not up to more than 5 centimeters, or 3 tumors, none bigger than 3 centimeters. No macroscopic vascular invasion, no extrahepatic spread, no lymph node disease. And especially in Germany, and I think in the Western countries, each health system has their own regulations, and in Germany especially, it's like if you have a patient with an HCC fulfilling the Milan criteria, you can get extra points for the patient during waiting time. So they start usually with 22 points, and every 3 months they get 3 points on top. But unfortunately, if you have a patient that has a single nodule with 5.1 centimeters, you don't get extra points, what is not really sensible in my opinion. Of course, the Milan criteria have been expanded, again by Mazzaferro et al., Lancet Oncology, 2009, the up to 7 criteria were published, and Mazzaferro could show that the 5-year survival rate, if you stick to the up to 7 criteria, that means largest nodule plus number of nodules equal or below 7, you can reach the same overall survival as with the classical Milan criteria. This was called the Metro ticket. So next publication on Beyond Milan or expanding Milan criteria was the Metro Ticket 2.0. Again, Mazzaferro this time published in Gastroenterology in 2018, and this was the first time when somehow biological behavior of the tumor came into the criteria, but they only took like AFP, but still it's a marker, and the 5-year overall survival is so dependent on AFP levels, number and size of nodules. So up to now, I think in the western part, we would say LT in HCC fulfilling the Milan criteria is somehow the gold standard for the treatment of HCC in cirrhosis. But and I think every transplant program faces this problem. We have organ shortage and we have decreasing organ quality. If you look at the European Liver Transplant Registry data, you see donor ages increases over the years. Year by year, we have much more elderly and elderly donors. And if you look at the right side, the quality of the organs is also decreasing. For instance, here also data from liver transplantation 2015 from Amran and colleagues. The red line is the rate of the diabetic donors, and the yellow line is the rate of the obese donors per year, deceased donors. So if we think about resection in HCC and cirrhosis, of course, as I already mentioned before, future liver remnant is a very important thing. In healthy parenchyma, you can perform huge liver resections without problems. You need a residual volume of about 25 to 30% for safe resections, but in injured and damaged parenchyma, you need much more volume to remain, especially in cirrhotic patients. And if you see at the pictures, of course, on the left side, very cirrhotic liver, you only can do like atypic resection, and on the right side, a fatty liver, but still better quality. You can do extended resections, also combined with atypical resections on top. So what do we do in my center? So how should we look at the liver function? Child and MELD is not really a good measurement for liver function. If you plan a resection, what we do in our center is we established a special liver function test. It's the so-called LIMAX test. I will give another talk this afternoon about remnant liver evaluation, but just real quick, this is a test where the patient gets IV C13 marked metacetine, that is a prodrug of acetaminophen, and this is metabolized in the liver to paracetamol and CO2, and you can measure the C13 marked CO2 in the exhalation, and from that you get a special value, and we have some values where we can say, okay, liver resection is possible or is not possible, and you always should combine this with volumetry and liver volume function planning. And from many papers that we did on this topic, we could see that the estimated resulting liver function by the test really good correlates with the postoperative outcome. So sophisticated remnant liver volume planning is necessary if you do resections in cirrhosis. So what about minimal invasive approaches? This is the Orange 2 study long ago from the Netherlands, Kees de Jong, who unfortunately already died last year, I think, and Ronald van Dam. They did a lot of work with establishing minimal invasive laparoscopic surgery. Then we had, of course, the consensus guidelines for laparoscopic liver surgery, and the most recent thing is that we already compare by propensity score matching last year in JAMA Surgery, published by many recommended surgeons, a comparison of laparoscopic and robotic liver surgery. So minimal invasive liver surgery in HCC is already established. You see from this meta-analysis, 44 studies, more than 5,000 patients. Of course, we know after minimal invasive procedures, we have less blood loss, we have a lower morbidity, lower mortality, we have a shorter hospital and ICU stay, and this is all covered by non-oncological differences concerning DFS and OS. In our own center, of course, we, when establishing the minimal invasive liver resection programs, we also made propensity score analysis, and this is open hepatectomy versus minimal invasive hepatectomy, and we found the same things as in the already shown meta-analysis. Length of stay was significantly lower, complication rates and major complication rates were significantly lower, liver insufficiency in minimal invasive hepatectomy was lower, and also 90-day mortality was significantly lower after propensity score matching. In the beginning of the learning curve, of course, for minimal invasive procedures, you have longer operation times, but as Daniel Sharkey already said, minimal invasive surgery shifted the pain from the patient to the surgeon, but I think it's worth it. So these are where the outcome results. We could show with our minimal invasive procedures in HCC patients that we have non-inferiority compared to the open procedures. This is our program at Charity. In the last 8.5 years, we did about more than 1,000 cases, and a quarter of these cases are HCC patients. So in 2018, we started with the robotic system, and per year we do about I think 100 minimal invasive procedures. This is not all HCC, but a quarter of it we do. So now I would show you a little case presentation. This is a 61-year male, biopsy-proven HCC beyond Milan criteria in alcoholic cirrhosis, child A. You see, it's a difficult situation because the tumor is here in the hilum and expands the portal vein, also hit the hepatic artery, and it's very close to the vena cava. And transplantation was not possible for the patient. We did liver function testing. Liver function was enough for this resection because for this resection we estimated that the tumor will have a pseudocapsule, so we would enucleate the tumor in this area. We used the robot system for it. As you can see, some adhesions, of course, removal of the gallbladder. Here you can see the tumor. It is freed from the vena cava. Then we always put a Pringle for resections, for minimal invasive liver resections, just for safety reasons and also for having less blood loss. So step by step, the tumor along the pseudocapsule is then freed with electronic device. In the robot, unfortunately, you only have the harmonic scalpel. You don't have other very good things to use there. There you see how the tumor is left from, freed from the portal vein. Some small branches that go to the tumor are selectively clipped. And so, step by step, the tumor can be freed, minimal invasively. Again, some clippings. And here you can see the result. It was an R0 resection. You can see here the hepatic artery, what was very close to the tumor. And the patient recovered very well, and after 5 days could be discharged from the hospital. So in our center, we compared liver resection and transplantation for hepatocellular carcinoma in cirrhosis inside the Milan criteria. And in the earlier area, as you can see here, the overall survival difference between liver transplantation and liver resection was significantly different. But in the newer times, this significant difference is not seen anymore, what is a very important thing. We have more technical developments, more experience with liver resection, so the gap between the outcome between transplant and liver resection is kind of not there anymore. So we had the anatomical targeting, but I would say due to the excellent results of in the last years of the systemic therapy, we more and more will have a biological targeting. So these are the milestones in the development of the modern systemic therapies, and I always tell my fellows, this is not only the job of the hepatologist or of the oncologist. You have to know what they do. Otherwise, you cannot discuss with them in the multidisciplinary turbo board, so you at least should know some of these studies. And the most important ones, I say, is the Himalaya trial and the IMBRAVE 150 trial, where the immunotherapy with anti-angiogenetics were used. Just real quick, maybe it's not too boring for surgeons. These were patients with child A cirrhosis, therapy naive with non-resectable HCCs. They received atezolizumab and bevacizumab compared with sorafenib, and with the new therapy, overall survival and disease-free survival was significantly better. And the same with some other medication, tremelimumab, durvalumab, and durvalumab mono against sorafenib. Again, the STRIDE scheme had much better results concerning the sorafenib. So this is another case from my center. This was a 63-year patient with an advanced HCC in HCV cirrhosis, initially, unfortunately, deemed unresectable. You see the large tumor here in the MRI, very close proximity to the bile duct and to the portal vein, not enough liver function for a resection. So in interdisciplinary tumor board, we said the patient needs AT-BEV, that is systemic therapy, and after 6 months in restaging, you see very, very good result of the systemic therapy. So the patient was referred back to us. We did a Da Vinci R0 resection, no complications. 6 days later, the patient could leave the hospital. So I think, as I just mentioned, we will more and more go away from anatomical targeting to biological targeting. And this is not also the case in resection, but also in ablation. But due to restricted time, I cannot talk about all the ablation studies that our interventional radiologists do together with the hepatologists in combination systemic therapy and ablation. So this is another very important press release from the beginning of this year. This is from the IMBRAVE 050 study that was investigating AT-BEV in adjuvant therapy after early stage hepatocellular carcinoma with high risk of recurrence. That means with patients with bigger tumors and patients with vascular or microvascular invasion. And the endpoint was met for a better recurrence-free survival if you compare it with no adjuvant therapy. This is something very preliminary from the colleagues from America. They used the PD-1 inhibition as bridge to transplantation. So 9 patients, they received PD-1 inhibition until transplant, deceased donor transplant. Usually we are very, very cautious about immunotherapy for transplant patients because we are in fear of rejection. But if they stopped at the transplant the PD-1 inhibition therapy and they experienced no rejection, no recurrence after 16 months and no deaths, very preliminary data, but very interesting, I think. So if you put all this together, like our surgical efforts and the systemic therapy efforts and the results that we get out of it, and the gap between the transplant and the liver resection is not significant anymore, I think in the near future we will have a change of the liver transplantation allocation because we have longer, or we will have longer disease-free survivals due to adjuvant chemotherapy or immunotherapy. This is some future perspective. What about downstaging of locally advanced HCC? Just some case studies. But if you look at the imaging on the right side, why is the patient deemed unresectably? Sometimes it's just only some millimeters of proximity to bile ducts or to vascular structures, and if the systemic therapy is able to give us this some millimeters, the patient might be referred back to us for resection, and when we could do also adjuvant therapy, and I think this will revolutionize the therapy, the surgical therapy of HCC. So thank you very much for your kind attention. I now come to the summary, some take-home messages. From my Western perspective, I think more and more interconnectivity of disciplines, surgery, hepatology, oncology, and less linear causes of disease will be seen in the future. Decreasing morbidity and mortality due to minimal invasive procedures, laparoscopic and robotic. And I think liver transplantation increasingly will only be for patients with really severely impaired liver function. We have multiple new systemic therapies in the first, second, and third line, and we should be aware of this when we discuss with our hepatologists and oncologists in the multidisciplinary tumor board. And the increasingly use of immunotherapy will step over the stages, not only in the advanced stages, but also in the early stages. We will have adjuvant therapy, we will have adjuvant therapy in combination with ablation, we will have downstaging and neoadjuvant therapy in the future. Thank you very much for your kind attention.